So we will be moving to our next case. This is a 48 years old male with one eye pseudophakic and the other eye has a hand movement vision with Morgagnian cataract. As you can see, there is white fluid and the nucleus has settled down. This is the other picture. You see some calcified capsule also. So this is one of the challenging cases that for today. And when we see the biometry shows a 20.5 diopter lens. And in the variant, the plan is for a Torby lens, 20 diopters with a cylinder of 2.5 degree diopter at 165 degree axis. Over to Dr. Gaurav Luthra, who would be doing this case.
Very good afternoon from the cataract OT. This is again Gaurav here. So we are going to start off by marking the cornea for the toric lens. We are using the Virion guidance system, and I will put my check marks as I told you about before we started operating, when we started operating last time. This is a Morgagnian cataract, and हिलना नहीं है, लाइट में देखिए. So these are the check marks. Put xylocaine drops. Xylocaine drops. This is xylocaine? Okay. So I'm just putting a few drops of xylocaine. Patient is feeling uncomfortable. I'm hoping that he'll be cooperative during surgery. So that won't, okay. I'll use Virion for the Rhexis this time. Can you switch it to the incision? Okay. So side ports there, and now the second side port. And this being a Morgagnian cataract is, and the capsule is also fibrosed. So lignocaine please, yeah. Thank you. So now we'll be making the main incision, main port, and then I'll put a dye. So the patient, and there seems to be phacodonesis also that I can make out, and I'm hoping that this does not become a real complex case for you guys to see. So a 2.2 incision, trypan blue, I'll put a little bit of air over here. Fine. So I like to put air. I'm now putting trypan blue, sir. It's good to stain under air because it's more uniform and with less dye, and it tends to stain the capsule better. And this area there is some fibrosis, so I'm hoping that the stain will take up in that area. I'll go back and try to put a little more trypan blue over there. It's not taking stain. I hope there is no vitreous over there already. See, there is vitreous. So we'll have to do a vitrectomy first. I was seeing that there's no stain coming up there, so my thought about phacodonesis was correct. So we have vitreous already here. We'll need capsular hooks, I think, as well after the vitrectomy. So should we call the retina surgeons or should I proceed? Okay, let me try my luck.
This is a just 1 to 2 clock hours.
Cutter. Yes.
So you prefer to put
so the good thing is no tricot is not required because trypan blue can stain vitreous nicely also, as you can see here. And so I'm not putting viscoelastic because that will then kind of, so I think we'll tell Aditya to be ready in the other OT if we want to shift. this patient there later on, not right now. Not right now. Let me try my luck. So we are setting up the vitrectomy now. So I'm not going to do more vitrectomy because then the more you do, the more vitreous keeps coming. I'll just replace it with viscoelastic now. Viscoat. So I'm keeping my infusion on so that it doesn't tend to come back. And now I'm going to replace it with viscoat. I've switched off the infusion. Okay. So now we'll initiate the Rhexis. I need some visco to put on the cornea. Yes. Okay. Yes. And globe stabilizer. And then keep the micro Rhexis forceps ready. Can we increase the illumination a little bit?
Yeah. Yes, illumination.
So after I start the Rhexis, we might want to switch off the Virion. We'll see. It's a very thick capsule, and I've been able to lift up. See, here I was anticipating a problem. It may not go through. I'll need more viscoat now because there's a fibrotic band over there, and we may need a micro scissors. I don't know if we have a micro scissors.
Yeah, definitely.
If I'm not able to negotiate that. And I don't want to put too much viscoat either because that will push the bag behind. So I've just put enough that. So you can see this fibrotic capsule. I'm going to try and see if I can tear through it. Abhini. So I'm unable to hold that flap because no, it's because it went behind because of the viscoat. You can see that if I try to tear it, I'll create a zonular dehiscence. So I'm not going to try and tear it. The bag is very flimsy. So I'll cut there. हिलना नहीं है आपको, हिलना नहीं है, आराम से लेटो. So I think we are in the process of preparing. We are back up. Let's do our best. हाँ? अभी तो मेरे को दिख रहा है. No. So we now have a nice scissors available. I'm going to cut through that area where I had reached. And it's really stiff. It's hard. You can see that it's kind of calcified almost. And now I'll again try my luck on trying to tear it, but it doesn't look like it is going to tear. So I may have to complete it all with scissors wherever it doesn't tear. Micro scissors, micro forceps. Yes. So I'll give one more shot. Sister, can you give me normal viscoelastic, please? HPMC. Actually, viscode can create pressure in the chamber, so I don't want that to happen. So I'm just clearing up some of that. Forceps. So I have an expert standing by next to me. It's tearing in a peculiar way because it's very thick, but as long as it's tearing, I'm okay. Visco. Problem is that when I go in with the phaco, if vitreous starts coming back, then we'll have to. So we have a smallish Rhexis, but at least we have a complete Rhexis now, hopefully. And now we can go with the phaco. We'll go with a hard chop.
So, do you prefer to put capsular hook now, or
I'm not
you just
sure.
try to?
I'll first try.
Yeah.
If it doesn't work, then I'll have to put capsular hooks. Yes. 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 Now the trick is to engage the nucleus. So I'll use higher vacuum, and we'll use higher bottle, and not very high bottle height because I don't want too much pressure inside. Yes. Okay. So the benefit of all the fine instrumentation available in the hospital here, the moment I asked for a scissors, it was immediately available, and that was made my life so much easier. Otherwise, we would have been struggling with this. Okay, so chopper. Can you put some xylocaine drops also? I mean, from there only. Yes. This isn't a topical anesthesia, so we have to be careful about that also. And our Rhexis is really small, so I'm hoping. नहीं भैया हिलना नहीं है. He's kind of not very cooperative, so you can see the big nucleus now. I'm going to try and embed. It's quite risky to try and embed such. No. So I don't think we'll end up putting a trifocal lens in this patient. I'll want to put a CTR if everything goes well. But first, of course, let's get the nucleus out. I'm beginning to see vitreous coming up again, and I might want to do a vitrectomy. I can see some vitreous. Can we get triamcinolone? Visco? Okay, first give me triamcinolone and prepare the vitrector. There is vitreous over here. All this is vitreous, I think. Want me to check? It looks like vitreous. No, it's a big chunk over here. I don't know from where it's coming. Let me see. If it's coming from outside the bag, then we'll know. No. So it may not be vitreous, it may be cortex inside. Let's see. I'll try to proceed, we'll know. Yeah, it could be viscoid. So see, the nucleus is big, but it has gone to the side. And I'm hoping it's not going to drop somewhere because there is no support. There is no cortical support and it's hiding to one side. And sometimes the equator is also broken in such cases. So it's not wanting to come back. So I'm having trouble in bringing that chunk back. I'll put viscoelastic and then rotate it. Not this, other one. The nucleus is stuck in that side. I'm going to put some visco from here. And we'll see if we can mobilize the nucleus. And just give me xylocaine. I'll put some intracamerally. Yeah, I'll do that. Chopper. Thank you. So I'm going to try and rotate the nucleus around. I know, but it doesn't want to go where I want it to go. I want to bring it around to the inferior, like, yeah, now it is gone there. So I want it here actually. And I'm hoping there is no vitreous. Okay. So do you want me to check for vitreous or should we just proceed? Huh? Okay. So Dr. Kumar is suggesting I put some viscoat below the nucleus to keep it there. It's a good idea because if I fill the rest of the bag with viscoat, it won't come to this side again. And it will keep the nucleus, it's like a tamponade and keeps it where you want to keep it. So we are all set. Fico, yes. So now we'll just try our luck. Yes, keep it the same settings. हिलना नहीं है भैया. हिलिए नहीं. So I'm negotiating the nucleus out of the bag and going to try and crack it into two. The trick in hypermature cataracts is to get a good hold on it and crack it. And now I'm bringing out this chunk and I'm hoping that I can emulsify it. Quadrant. I don't want to break it into too many small pieces because they will go away from me. I want to eat it up as one piece. Because if I chop it into smaller pieces, they will not come back to me. So I want to kind of eat it without breaking it into too many small pieces. In fact, some of them will also find their way behind the capsule if I do that sometimes, and then it's impossible to kind of get them out. One piece also should be there. I can't see it anymore. I hope it's not gone behind. But there was one more piece to the best of my knowledge. I think there's a big PC break in the periphery there. And probably there's a small chunk which has gone behind which I can't do anything about. No, it's not visible. To my understanding, there was a small piece still remaining which may have gone. I can probably feel there's a break in the peripheral equator of the bag. Viscoelastic. So I don't think we should put a lens for this patient right now. That's my thought. Because first of all, if at all, I'll put a retrofixated iris claw or something, because the bag is not looking intact. And to my understanding, there should be a nucleus small more piece remaining somewhere. I'll just check for a PC break in the periphery. Although I didn't create it myself to the best of my knowledge, but I think the capsule was already unhealthy there. So I feel that there may be a peripheral break somewhere in the equator over there.
That's why that's a vitreous was coming.
Yes, yes. So that periphery, I think, has some. I'll go and check. Give me the white-tipped spatula. Yes. No, this is capsular fibrosis, but where is my...
Small piece.
There's one small piece which I thought was there. So there the bag is, of course. Do you want me to try and put a CTR? See, I can see something moving behind in the vitreous. It could be that small piece which has gone behind.
Yes.
Hmm? Should I try putting a CTR?
Yeah.
Okay, I'll try putting a CTR, because if we have to remove that nucleus piece, we can also remove the CTR if it goes behind anyway, right? See, that thing is moving behind, so I think there's a small drop. I don't know from where it went, because
This is from the
zonules, yes.
Same
Probably found it.
zonular.
So that's why, see, I didn't want to break it into smaller pieces. I wanted to finish it in one go. I was not cracking it into smaller pieces, but still some small piece was. So, can CTR?
CTR.
See, this could also be dye which is moving behind in the vitreous. Sometimes the dye stains the vitreous, and it may not be the nucleus, it may be the dye coated vitreous also which is there. So we cannot be 100% sure. But I think there was one more piece. Bigger size. You have two sizes, right? Yeah.
Yeah.
Okay, so you want
Dr.
me to close
Luthra,
it?
this is from the auditorium.
Okay.
Hello.
Hello. Yes.
Wait a minute. Just wondering if you suspect there is a small peripheral tear somewhere, and just wondering whether
CTR should be put or not.
put a CTR in the first place earlier so that it wouldn't happen, or now if you think there is a tear in the periphery, whether by putting a CTR it will compromise the bag more, chances more.
So till now I did not need the CTR because the bag was not collapsing so much that the CTR was absolutely necessary. But now, if I'm putting a CTR, I'm going to tie a 10-0 suture to the CTR before I insert it. Ethylone. We'll just tie it to the eyelet of the CTR so that if it starts dislocating, we can bring it back.
Okay. Okay. Thank you.
So this could be just trypan blue stained vitreous.
Yeah, maybe. But during OT, we do not suspect anything.
Sorry? It looks like stained vitreous, right? So we'll quickly tie one suture to the end of the set eyelet and put in the CTR and then see. I'm sorry we are delaying the OT, but I know. But thankfully the nucleus is out, most of it, and if something did go behind, hopefully, yes. Hopefully, yes. Sorry. I will to nahi dalenge. Huh? No, it's better to just, it's the correct way to do it. Yeah. I actually described this 10 years back. I'm sure other people would have done it separately at their own places, but I remember showing this in the iOS 10 years back and then. हाँ कट करके बस छोटा सा पीस चाहिए उसको उसका एक फ्री एंड को ना आई विल टाई इट टू द आईलेट जस्ट कट इट इनटू टू एंड गिव इट टू मी गिव वन ऑफ देम टू मी हाँ हाँ ठीक है नॉट टू स्मॉल बट okay, so I'll take the suture first and then you give me the CTR. And I'll want a good suture tying or a Kelman or something. In fact, we'll just pass it through it and just, I know. Yeah, that's what I'm planning to do. I'll just pass it through it and then, okay. Yeah. No, but even to hold it, I'll need a good Kelman or this thing sometimes. Or maybe if the needle goes through the eyelid, non-tooth. Kelman, with the Kelman, I'll hold the CTR now. Just give me one Kelman. Kelman forceps, here. Okay, this is mine. Okay, now give me the CTR. Yes. Show me here only. You can bring it here, please. The CTR. Can you show it under the microscope? No, just bring that under the microscope. Have you opened the lid of it? Is it visible? Yes. Now just bring it here, please. And I'll try to pick it up. Oh, this is a CTS.
This is CTS.
These are CTS.
Not that.
We want a capsule tension ring.
No.
These are a pair of CTS.
This is a pair of CTS. No.
Keep this carefully. You can ETO and use it. Huh? Yeah. Will the needle go through the eyelid or should I pass the free end? No? That's what I normally do, but नहीं जाएगा. Just put drop of Xalocaine there. He's quite uncomfortable actually. So had I known there was going to be all these things, I might have blocked him also, but no point, because right now it's okay. अब तो खत्म ही हो गया. So what IOL should we put if the CTR is able to inflate the bag? Not a trifocal, I think. So what do we want to put?
What do you have ready besides that? I think multi-piece are...
Multi-piece would be good, but if CTR inside, then we can even put single piece. हाँ. If you have a...
This is not a multifocal, this is a single piece plate haptic tori.
One second. Okay. So now the question of from where to start putting the CTR. I think we'll go from the main port only. No? You want me to go from the side port? This one? Okay. Oops. So give me a Hoskins now. Here. Hoskins is. I think I'll put it from the main port only, but do you want me to put it like this or like this? This way? Oh, other way around, right? So I also thought I was going to do that. Yes. And see, this good thing is that when I put it from this side, I'll be avoiding that area to some extent. White tipped my manipulator. Okay, this is fine, but give me Viscode. Heel on GV? Achha. Dialer system.
Bag looks intact.
Yes.
Absolutely perfect.
Dialer. There's a dialer here. Okay. So now we can probably put in a lens. Single piece lens. If you not toric. Toric? Okay. Okay. But not. Let's not put Zeiss plate haptic. Huh? Huh? See, actually, to put that thing into a small Rhexis, now you have to use a lot of force to put it inside. So that's the only thought. Huh? If Hoya lens is there, that would be the best for me because with the multi-set. Alcon single piece? Okay, I'll use that. Yeah. Although I could have put a toric if my Rhexis was little bigger. I would have put the Zeiss toric only. But with a plate haptic and a bag which is not very strongly supported, I don't want to take a chance. You know, trying to get it into the bag, it might just dislocate the whole bag. Also see toric lens here, of course, because now everything is done. We can easily put a toric otherwise, but I'll remove it at the end. I'll just have to cut one end and it'll come out. Huh? Yes. So now we'll just do irrigation aspiration like cortex, visco removal. So we are preparing a single piece lens now, which we want to implant. We are not using a toric lens at this time, and we are definitely not using a multifocal lens. We could have used a toric actually because now the CTR is there and everything is done. But in the correct par, we don't have toric because what was prepared was a multifocal toric lens for this patient. So the sister here is very efficient. She's doing everything perfectly. And hopefully now we'll have a lens in the bag. The patient will do well. Okay. Yeah, it looks good. Just give me a manipulator. Yes, this one. Yes. Just put Xylocan drops, please. Just tell the patient that there will be some discomfort. I'll put little viscoelastic, huh? Regular viscoelastic, yes. I'm inflating the bag. Should I remove the suture according to you? If I go under it, no. You think it will catch? I'll remove the suture. Just give me a scissors. Any scissors. Yeah. Yeah, I'll remove the suture. Because now we know that the bag is intact. So I'll just cut one of these. And then I'll pull out the other one. Forceps, this one. Sometimes this pulls the eyelid and it can cause problems, but here it goes. Okay, so now we are ready to implant the lens. And so I had to make sure that before the haptic opens, my lens is inside the bag. So now maybe we can close Give me bimanual viscoaspiration and everything. Yes, yes, yes. Whatever happens now, we don't need to show.
These are perfectly done. So
thank you everybody for bearing with us. A team effort by Dr. Kumar, Dr. Anand, and
Thank you, Dr. Luthra.
and Abhijit.
Thank you, Dr. Luthra. You did a terrible job, terrific surgery. It's very good. And that idea of putting the thread through the CTR just to be on the safe side is really a very good idea. Thank you. We all enjoyed.